name is Luca Lovrečić and I come from the Clinical Institute of Medical Genetics from the University Medical Center of Ljubljana. First, I'd like to thank the organizers for inviting our institute here at this meeting and to give us a chance to present what's new in genetics, in genetic diagnostics in general and of course in the field of neuromuscular disorder. As well as in the previous talk of Professor Židar, also my talk starts with definition, or not definition, but with the entity of a rare disease or genetic disorders which are rare as well by definition. And what was shown a few years ago in a big study performed in 16 European Union countries called the Discard Survey. It was shown that approximately 1/4, that is 25% of patients with genetic or rare disorder wait for their diagnosis between 5 to 30 years. And this is a worrying information. And also, not that they wait a long time, 40% of them are at first diagnosed incorrectly. And even so, approximately 1/3 of them get the information in the wrong way, without proper explanation of the importance or the depending on the disorder, but in general the information is not given appropriately. And also 25% of them, so of those patients, are not informed on the genetic nature of the disease, which is also worrying because genetics has implication for other family members, not only their children, but also their relatives in a broader way. And with advent of new technologies, which I'll be talking more about in this lecture, in the field of genetics, we are facing a completely other approach, so a completely different approach in establishing diagnosis nowadays. Because for the last, let's say, 5 to 10 years, more and more genes were related to specific diagnoses, specific disorders. And then if someone was suspected to have, let's say, Parkinson's disease in a genetic way, so it means that Parkinson's disease shows or starts early, around 40 years of age, and maybe runs in the family, then we think it's familiar. In that case, so more and more genes were added to specific symptoms, let's say, and here's a graph showing, for example, how gene panels were growing with years with specific diagnoses, and as I already mentioned, or named Parkinson's disease, and we can see that approximately 30 genes are now related to Parkinson's disease. And for example, we have spastic paraplegia, there are around 100 genes related to this disorder. And also, for example, spinal muscular atrophy, there are approximately 15 genes that are connected to this diagnosis. And of course, this also means costs related to genetic testing. But before we do know a specific mutation in a certain individual, for that time we cannot give any counseling with respect to the progression, maybe type of the disease, or also for the relatives and potential of how the disease is transmitted in the family or through generations. That's why it's really important to establish also a genetic mutation. But with the previous slide, where we were seeing that for a specific symptom or disorder, there are a lot of genes. Getting sequenced genes or looking for a mutation 10 years ago, it cost around 500 to 1,000 euros just to sequence one gene. And let's say if we have 15 genes for spinal muscular atrophy, the cost would be really getting bigger and bigger. And with these new technologies that are now widely used, or not so widely, maybe widely in the north and the west, but also be implemented at our institute, so it's possible also to be done in Slovenia, because are actually getting lower and lower for diagnosis. So if I said that 10 years ago sequencing one gene was costed around 1,000 euros, nowadays, through this revolution of technology, it's possible to sequence an entire exome. So it means all the genes that code for proteins for 1,500 euros, which means that with one test, we basically sequence all the genes, and we can just look for specific mutations related to the diagnosis or to the symptoms of the individual that is assessed. This is just for illustration how technologies are getting more and more high technology. You can see at the upper left corner that on this microscopic slide, basically you test all genes at once for approximately 15 to 30 individuals. Not to get more into the technology part of it, but just to illustrate how simple it looks and how things are getting more and more developed. Why is this important? It was also mentioned in the previous talk that with having more and more knowledge about genetics, about mutations, about function of specific genes, and even more is not known that is known now, so this knowledge is getting bigger. This approach, which is called next generation sequencing, that means that we look at all genes in one test, is very important because for specific disease there is large extent of genetic heterogeneity. So it means that for one disease, as is for Charcot-Marie-Tooth disease, for example, there are a lot of ways of how this type of disease is transmitted, which genes are mutations in which genes are responsible for the disease. So it means that for one disease, we have a patient with a disease, we will need to test 15, 20, 40 genes. And doing one test, it really brings not only cost down, but also time management. So it's also quicker, the results are quicker. And there are also many diseases for which part of the patients get their genetic diagnosis or we find the mutation, but for another part of the same group we just simply don't find the mutation. Because up until now we were looking for, let's say, into 20 genes, and if the mutation wasn't there, we didn't find it. So we assume that there are many more genes related to specific diseases which are currently not known, but with expanding knowledge in the world, of course, and with many exome sequencing being done in different types of disorders, the knowledge is getting bigger. I have now a few examples from our institute, not also for neuromuscular disorders, but not only for neuromuscular disorders, and for now outside of Parkinson's disease, because this is just an insight how this new approach helps us. This is a big day where we see that in 2 generations there was a Parkinson's disease, and it started really early at the age of 30. There is well-known panel of 5 genes for this type of inheritance of Parkinson's disease, but there are many other closely associated also with familial Parkinson's syndrome. And as I mentioned now a few times, it's much easier just to sequence an entire exome and then specifically look for mutations in more genes, let's say for all the genes in this table, not for only 5 that are listed here down here. You see panel for autosomal dominant Parkinson's disease. And of course, if we look at the specific family, only in those 5 genes there was no mutation. But then again, if you see the loci part 9, which is just below the second violet rectangular, we found a mutation in the gene, which was the causal mutation that in this specific subject, although up until now, this gene was not related to autosomal dominant way of inheritance for Parkinson's disease. But according to the way the information is interpreted in the database, this is a damaging mutation. And after that, we were going through the literature and we found And another case, so just another case in the literature with the same symptoms and actually the same mutation in the same gene. So we believe that with this sort of sharing information, probably not only with Parkinson's but definitely with all genetic disorders, with growing knowledge we'll be able to find specific mutations in many disease groups. Another example was a patient with dystonia, which was referred to us under the, so supposedly having autosomal kinesiogenic dyskinesia, which is related to specific locus Z10. But after interrogating this patient more deeply, we found also that it could also be another type of dyskinesia, which is exercise-induced dyskinesia. And also, again, if we would only test for the first indication, we would miss the mutation, which was actually not in the DIT10, but it was in the DIT18 locus. Again, we found a damaging mutation in this family. It might seem simple from these two cases, but what I want to show you is that doing a typical exome, so I mean in each of us here, not only the patients that we assume have a genetic disorder, but also in normal controls, if we sequence all the genes, we will skip the first two steps, but if we only look at the third one, so rare variants, and this could be damaging, in each of us, in each one of us, there are more than 200 variants that are specific to us, or maybe only a few, probably other family members. And then if we check all the databases, we still have more than 100 variants which are damaging according to program. So it means we should be ill in a way that genetic information is interpreted these days. So it's really challenging to interpret the results that we get out of this enormous amount of data. These are millions and millions of genetic data that we get from a single individual. And I'd like to show you another case of congenital myopathy. This is a little girl presenting with hypotonia, joint hyperlaxity. The distribution was limb-girdle, and biopsy was not indicative of any specific type of muscular disorder. And the first suggestion was so a few years ago, of course, to sequence a Fukutin-related protein, which would be the first one related to these symptoms, but this was negative, so there was no mutation for this girl. And after filtering all the genes, all the data that we got from the exome sequencing, this was the list of damaging mutations. So there's a lot of problems. Obviously, our body has mechanisms to overcome a specific amount of mutations that are supposed that need to be pathogenic, so disease related. But anyways, in this girl, there's a lamin A gene that is related to these specific symptoms. And we saw, after we found the mutation in the girl, so the first thing, we cannot just say, yes, this is the mutation that's causing the disease. We have to prove it's the normal, because if you remember the pedigree, only the girl is affected in the family. So it's very important to show that the parents do not carry the same genetic defect, because otherwise this could not be actually related to her symptoms. And yes, this is how the sequence then looks like if we only check a small part, and we see that father and mother carry another signal, so it's not the same signal at the same spot. And that's therefore the girl has no mutation, which is the reason for her disease. With this new approach in genetic diagnosis, which is now in the time of being implemented into regular clinical practice, so it's not that common. Probably Slovenia is the most southern and the most eastern in Europe that has this technology, so there are many countries that do not still have it. But we can see the diagnostic yield using this whole exome sequencing, which are represented by the green bars, is quite importantly higher than as to the previous methods where only specific genes were looked at. So this is good for the patients and for the clinicians because we solve many more diagnoses than before. Because there are many patients with rare and diseases and that are still not diagnosed. We have 2 centers established last year at our institute, closely related between each other and also with this new method. Which are centers for Mendelian genomics, or genetic diseases, and of course for undiagnosed rare diseases. All that I've mentioned so far relating to these new approaches sounds very optimistic, and it looks, as I said, simple, but it has important issues or challenges behind it. This is also seen if you look at how many guidelines they exist. On the European level, in the United States, Australia, everybody's trying to put some specific rules into it, and I'll just explain in the last 1 to 2 minutes why. This is not intended to be read by you, but what's the problem? Now, up to now, we were looking for, let's say, having a patient with specific symptoms, we would check all 3 genes that were so far related to the diagnosis, and if we did not find the mutation, we would say, well, we didn't find the mutation, and that's all for the genetic part that we were able to do at that point. Now, when we do the entire exome, if we don't find a specific mutation in the first genes that we look at, and these are the panels that I started with, so genes that are with knowledge that we have now related to specific disease, these are the genes that we first look at. We don't just look at the whole exome. And if we don't find a mutation there, then we do look at all the genes. But at that point, there's a chance to find a mutation somewhere that we were not looking for. For example, if we have a patient here with a neurological disorder, and we check for all the genes, we can see that that woman also carries a BRCA mutation, which is indicative of a breast cancer. Or we can find specific mutation for, let's say, Parkinson's disease or Alzheimer's or many other diseases, and these are so-called incidental or unsolicited findings. And these are important ethical or rather practical issues that have to deal with these guidelines, within these guidelines, and also with the patients. It's very important that we counsel patients correctly before the test. There are patients who say, no, I rather not know nothing than found out also these incidental or unsolicited findings. So these are some challenges that we have now by being able to see the whole genetic background of an individual and how to look at the information, where are the boundaries, what do we share with the patient, where do we stop, where do they stop, and so on. This is why genetic counseling is very important prior to the test, and also informed consent of the patient is a very important issue here. Not only these incidental findings that are things that need to be taken into consideration, but also it happens that we find a variant in a gene that is related to this disorder, but we are at current point of knowledge not know what this mutation means. So basically we call it a variant of unknown significance. This also is something the patient needs to be aware before the test. This is very important topic in the pregnancy, let's say, constellation. If there is a pregnant woman ill by herself and want to have a test, what happens if we find something like this with her sample? So there are many issues here. which are being and are regulated, but are still up to discussion not only here, but also in the broader aspect of genetic testing. And I would like to start with this, and thank you for your attention. And this is the team at our institute. The head of, I would like to, of course, without our head workers, we would not have technologies. And then there's the team dealing with technological and interpretation part, Aleš Mavr has it. And then there are 4 of us of clinical geneticists dealing with patients. And thank you very much.